صباح الخير جميعا. Let me just start by thanking Dr. Muhammad Abdel Hafiz for inviting me to this conference, and Dr. Adina Taban, thank you for inviting me. I'm the alien amongst you. I'm the ENT surgeon, and for once I will not be bringing any foreign experience here, because this is very much a third world country disease, mucormycosis. So it's extremely rare in the Western world. During the spike in 2020 and 2021 of COVID-related mucormycosis cases, in the UK we've had just one reported case. So today I'll give you a bit of an insight on this horrible disease, COVID-related Rhino-Orbital-Cerebral mucormycosis. So what is mucormycosis? It's ubiquitous. It's everywhere in the soil around you. It's in the environment. It's in the atmosphere. It belongs to a group of fungi, the mucor group particularly, and it implants into the sinus mucosa, into the conjunctiva, into the oral mucosa, as it quickly invades carbohydrate-rich foods. So what does mucormycosis do basically? Its basic pathology is necrosis, vascular thrombosis and necrosis. The hyphae invade the blood vessels, the intima of the blood vessels, and cause endarteritis obliterans. So basically it shuts off the blood vessel, causes necrosis to the tissues, hence the name that the BBC was very interested in, and they produced multiple TV programs on the black fungus, which caused a bit of confusion because the fungus is not black. It's far from black. It's the tissues that the mucormycosis attacks and involves that turn completely gangrenous and black. Unfortunately, fatality is up to 80%, anywhere between 50 and 80%. So there is probably no favorable outcome in a case of invasive fungal sinusitis, particularly mucormycosis. Having said all that, the incidence is still extremely low. So it's an extremely rare disease prior to COVID, and with COVID there has been an obvious spike, be it a very small spike. So the highest recorded cases in the world was in India. India is about 1.2, 1.3 billion. They have a good healthcare system, and they have a good statistical collection, and they have 4,000 cases reported. So India is the country, probably the most in the world, that was ravaged, and they've had 4,000 out of a 1.2 billion population. So it's still relatively, thankfully, quite a rare disease. I've added here one of our studies in Ain-Shams University by one of my colleagues. So in the height of the pandemic in last year, between March and September, they had 12 recorded cases between the Mirdesh University Hospital, Ain-Shams University, and that covers the whole cases that were recorded between the surgical units and the internal medicine units. And looking through the literature, we will notice that mucormycosis was very rarely reported on or very rarely published on, but obviously there has been a spike over this past 2 years in relation to COVID-19. So generally speaking, what are general risk factors for invasive fungal sinusitis, of which mucormycosis is the worst? Number one, the most important one and the foremost is diabetes, whether it is poorly controlled diabetic control or patients with diabetic ketoacidosis, particularly in ICUs. Immunodeficiency with all its forms, whether it's immune deficiency or suppression, whether it's acquired immune deficiency, AIDS, iatrogenic by giving prescribing systemic steroids, which was the highlight of our COVID pandemic. all transplant patients are of risk of invasive fungal sinusitis. And this, particularly immunomodulation, tocilizumab, which was a favorite amongst respiratory physicians during COVID, during the COVID pandemic. I think it's called Actemra. Extremely over prescribed, and it actually, and I'll mention it in my next slides, it can actually facilitate invasive fungal sinusitis. WHO has actually put out an epidemiological alert that COVID-19 is in itself a risk for mucormycosis, for invasive fungal sinusitis, particularly mucormycosis. And I'll allude to that in my next slide. So what is the relationship, or why is COVID-19 an actual risk factor for Rhino-Orbital-Cerebral mucormycosis? I've bunched up the three top factors together because they are the single most important factor. Diabetes. Almost all patients, all patients had uncontrolled diabetes mellitus with various issues with their glycemic control. They might have had all sorts of comorbidities: renal, liver, organ failure, high blood pressure, anything. But it was diabetes that was the cornerstone of their poor outcomes. So poor glycemic control in itself helps mucor become, or invasive fungal sinusitis in general, become more invasive. Mucor itself produces the ketoreductase, which helps it to thrive in the acidic and glucose-rich environments of poorly controlled diabetic states. And there is also evidence that COVID in itself, it is not very strong evidence, but it's evidence nonetheless that COVID can attack the pancreatic cells, altering or making it harder for the patient to have a good glycemic control. So it's like a vicious loop. And the lack of diabetic control is not exactly that the patient is not compliant or we don't have good endocrinologists, but the disease itself wreaks havoc with the body's control, in addition to the insulin or treatment of the body's control of glucose. The virus itself induces lymphopenia. Equally important, of course, systemic steroids, and I add here hydroxyquinolone, which during our pandemic was actually declared under the Egyptian national guidelines for treatment of COVID. Another disastrous addition to management of patients with COVID. And it impairs, both of these impair phagocytic immune cell responses, which is the primary defense of the body against all fungi, particularly invasive fungal diseases. It's also recognized that with COVID-19, there is a hypercoagulable state, promoting easier thrombosis, easier occlusion of blood vessels, easier transmission of the fungus. It's a theory from within the ethmoid sinus over to the orbit. And lastly, as I mentioned in the previous slide, Actemra, it can precipitate invasive fungal infections by its well-known severe neutropenia as a complication. So the clinical presentation is unfortunately quite subtle. From an ophthalmologist point of view, I realize I'm amongst a body of ophthalmologists, and there are no ENT doctors here, so examination of the nose will not be possible. The findings of the eye can be quite subtle. I've just listed a few for sake of listing, frankly. Facial pain, headaches, facial swelling and numbness. The eye, there are all sorts of eye symptoms that I wouldn't want to mention amongst you because I'll probably get them wrong. Eyelid edema, ecchymosis, ptosis, proptosis, ophthalmoplegia, blindness. The message I would like to send out is, if a patient with probable or possible mucormycosis starts presenting with eye symptoms, then it's probably already too late, especially for that eye. I'm not saying too late for his survival, but I wish there was a way that these patients can be picked up with a simple endoscopic examination of the nose before an actual orbital involvement. But unfortunately, the patients have some nasal blockage, maybe some swelling in their face. They go and see their doctor, they get some antibiotics. No one puts the camera up the nose, does an endoscopic examination, because that will probably be only available in a specialist center, ENT center. And they don't think twice about it. They have poor diabetic control, etc., etc. They have other things on their mind. They go on with their lives. Next thing they know, in a few weeks, they show up in Watani Hospital with swelling to their eye, proptosis, ecchymosis. They are sent for a CT scan, and it shows a disastrous destruction within their sinuses with an orbital involvement. And frankly, in my opinion, that is already a very, very late stage of the disease. Some patients, many patients actually, will show up with palatal necrosis up to complete palatal perforation. And nasal symptoms again are nasal signs. Are all across the board. But the thing is, it rarely produces any discharge because, like I said, the pathology is death. Gangrene. Think about it as dry gangrene. Remember in the past we used to read about dry gangrene and wet gangrene. It is just dry gangrene. So actually going into this nose, you might operate on the patient without even using a swab. There is no blood during surgery. It's just black, charred, dried, ischemic necrotic tissue. But you need an ENT. You need an ENT surgeon to diagnose this patient early. I wish they had more of an ENT side to their symptoms, so that we would pick them up before the ophthalmologists would. Because once the ophthalmologists pick them up, it's quite late and advanced in the disease stage. So diagnosis. It's a clinical diagnosis, frankly, and you should exercise a very, very, very low threshold of suspicion. Radiologically, MRI scan, CT would do as well, but MRI is obviously superior, and I'll mention in the next slide why. A CT scan of the chest would be also useful to investigate whether there is also invasive pulmonary involvement. So what do we see? Sinuses, there are all sorts of pictures. The sinus might be full of grayish gunk, basically, inflammation. But the characteristic of invasive fungal sinusitis in general, not particularly to mucormycosis, is that you will see a variable intensity within the sinus. So in a sinusitis, the sinus would be homogeneously gray, for instance. With fungus, you will see mottled areas of whitish gray. On an MRI, you'll see a similar picture, but the most important sign or that will help you diagnose is the T2 hypointensity. T2 basically highlights fluid on your scans. The fungal involvement will show voids within the scan, which I'll show you in the next slide. And that is due to the fungal concretions and particularly the heavy metals that are in the fungal concretions. Gold standard biopsy, and the most important aspect of mucormycosis is that they are coencytic, basically unseptate hyphae, as opposed to another very important invasive fungal disease, which is more common in the chest, aspergillosis, for instance. Aspergillosis is septate, but mucormycosis is unseptate at 90 degrees, a very characteristic picture. I wanted to allude to the blood tests because over my experience in Egypt over about 6 months, I've noticed that a lot of chest physicians, I do not know if this is common amongst ophthalmologists, rely on galactomannan, which is a blood test to investigate whether they have respiratory fungal involvement, particularly aspergillosis. And there was an increasing overlap between suggesting that galactomannan, if the patient is negative, they have recovered from mucormycosis. That's entirely wrong. Galactomannan might be completely negative in a case with invasive mucormycosis. I will not discuss, I mean, I cannot attest to aspergillosis, but with mucormycosis, it obviously has no bearing on whether the patient still has systemic involvement or not. And of course, the rest of the markers will shoot high: CRP, ASR, derangement of their full blood count, white blood cells, etc. It's a very sick patient. This is a very sick patient with multiple problems, multiple medical problems. So just what I was talking about in the previous case, you can see the expansion, but more importantly, I want to discuss because you do offer CT orbits, I'm sure, in your line of work, and you might notice a kind of mottled appearance. Am I online? This multiple density. Yes, part of that might be the middle turbinate, but this variable intensity. So that very dark gray, that's the mucosa, okay? And that is probably some homogeneous gunk with some hyphae. But that mottled is quite suggestive, not necessarily diagnostic, but suggestive of fungus. And of course the expansion, so it's not a tumor breaking through. Same picture here on an MRI, you will see a double density. And here, a double density. Ah, yes, mucosa, but there's another mucosa, so that's probably not the mucosa. The mucosa is probably over there, and there's a double density. That's all probable, but it will kind of alert you. And that's with contrast, doesn't help much, but this is. So if a patient has an MRI scan, look at their T2. When you see a lesion there, boom, blowing up the ethmoid sinus, and on the T2 scan, there's absolutely nothing. It's a void. And that is the fungal concretions and heavy metals. So this is the important bit, the T2. So overall, unfortunately, there are no, I'm almost done. Do you want? Oh. Unfortunately, there are no favorable conditions with mucormycosis. But throughout the literature, there are a few bullet points that kind of direct the patient's prognosis and the outcomes. Whether there's a possible chance of survival, possible chance of cure, or a lesser chance of those. A previous COVID infection, almost all of them were post-COVID. Uncontrolled diabetes, and systemic steroids. And then with regards to the disease itself, orbital involvement, and particularly the apical involvement of the mucormycosis, very high morbidity. And lastly, if there is CNS involvement, frankly, the mortality is probably 100%. There are no obviously there are no studies on huge studies where we can draw conclusions. It's more of case reports here, case reports there. The biggest study was in India on probably 36 cases, 35 cases. So CNS involvement, if it has breached the skull base, probably the patient will not survive. So, management. This is not a patient that you will take on your own. No one can. Usually they are very sick. They have multiple problems, so it needs a multidisciplinary approach. Unfortunately, we all know that we do not always operate that way in Egypt. We do not have that kind of network where we work together. It's all personal communication. You probably might have that in Watani or in other big private institutions, but I'm talking about a completely not interdisciplinary team amongst you. I'm talking about completely different subspecialties. You'll need, of course, an ENT surgeon, ophthalmologists, oculoplasty probably, and also all the other ophthalmologists. We've just heard the talk about the neuro-ophthalmological side of COVID. And this one, there is mentioned very little in the literature. Microvascular surgeons, and I'll mention why. Of course, then you will need the internists who will basically control this patient's medication. This is not a fit and healthy patient where you're going to start giving a very, very toxic drug that will ravage their potassium, ravage their magnesium, probably give them renal failure if they don't already have a renal failure. So the internist is probably, during the medical phase, one of the most important key elements in this multidisciplinary team. The microbiologists, of course, they have extensive experience in the antifungal treatment, what to do, the dosage. Anesthetists and intensivists. This patient will spend a very large part of their recovery in the ICU.
Dr. Osama,
Yes.
I don't mean to interrupt, it's Dina here. Which kind of brings me to how this patient presents. Are you being called in amongst the team in ICU, or are they patients that walk into your clinic? Because we get them in our clinics, like Dr.
That is what I started with, my talk. That for once, I'm not bringing any foreign experience. If I was talking about the UK experience, that's exactly what would have happened. But this is not present in the UK. I've never seen this in the UK. This is in Egypt. And this is, as you said, personal communication, referral, and they come into my clinic. And within a day or two, they are in the hospital, admitted. I'll mention very quickly in the end my brief personal experience with 10 cases of mucormycosis in Egypt over the period of 6 months. When I started working, how many more minutes do I have?
Like 4 or 5?
Yeah, okay. So, the surgical management, aggressive surgical debridement, nothing stays. Easier said than done, obviously. So, you have to remove within the sinuses, of course, until you can see some fresh blood. Suggests that you have removed all the necrotic tissue. Think amputation. A gangrenous leg, you need to amputate it up to fresh blood. That is quite challenging inside the face and inside the skull. Antifungal treatment, most importantly, and the hardest part is the stabilization of the risk factors, diabetes, etc., etc. So the treatment, very quickly, we all know this, the gold standard, liposomal amphotericin B. We have nothing to do with the dose. It's a very, very, very toxic dose, very toxic medicine. Internists, intensivists, renal doctors control the dose because with the first injection, you will destroy this patient's like I said, electrolytes, and everything will go haywire. So it's not a surgeon's job, it's not an ophthalmologist's job. This needs, frankly, hospital admission and probably even monitoring in an ICU. With intolerance, which happens a lot, we give the triazoles. These are well known to all of us, Cresemba, Noxafil, Vfend. During the highlight of the pandemic, there was a horrible black market. The liposomal amphotericin in Egypt is about 800 pounds. It was being sold for 4,000 to 6,000 pounds per vial during the height. Patients couldn't get it, and they were dying because they couldn't get it. They had to rely on the orals, which are incomparable to IV amphotericin B. Very, very weak effect. They are good for maintenance. So I'll speed this up. Surgical management, as I said, wide field surgical debridement. The orbit is a question mark, which will be my esteemed colleague's talk. Yes, over there. Controversy. My view was, if there is doubt, even if there is vision, my view was, and still is, if there's any chance to cure this patient, the eye needs to go. It's a much harder decision, understandably, if there is vision. It's a much easier decision if there is complete ophthalmoplegia, a proptotic eye, non-functioning, the patient is happier to get rid of it. CNS, there's no surgery for the CNS side. And the microvascular flaps, this is the quick point, you bring in fresh blood. Probably our best patient, who did very well, received the microvascular flap, and it changed his life, and he's probably completely cured. I've just operated on him for the 4th time 1 month ago, and the mucosa is just red, beautiful, absolutely no sign of recurrence. Quickly, my personal experience was all private cases. I came back to Egypt in February this year, so I had a period of 6 months of experience, all post-COVID, all received steroids, 2 received Actemra. 3 cases had orbital involvement. I'm just paving the way for my colleague, Dr. Hatem. And I had 2 mortalities of those 10 cases, but 6 were mine. 4 others died in ITU I wasn't involved with. Case 1 was in a huge hospital in 6th of October for 2 months in ITU. Surgeons refused to touch him because he had an ejection fraction of 26, renal failure, heart failure, but his only chance of survival was a debridement, which we did. Here he was referred to me in 6th of October. I brought him over to one of the hospitals here in the east side of Cairo, and we operated on him. The second case that I'll mention very quickly, it's a very sad case. He's a professor was a professor in engineering university here in Ain Shams. He had minor mucosal disease, but purely eye symptoms. His surgery went very well. Unfortunately, he died about 2 months after surgery with recurrent COVID, recurrent mucormycosis, because in my view, he refused to have his eye removed. Very quickly, I show you, this is the case 1. This is what palatal necrosis looks like. As you can see, if you are just looking in the nose, you will see absolutely nothing. You need an endoscopic evaluation. Unfortunately, passed away after spending 3 months in ITU. His heart couldn't take it, even though locally the disease was controlled. This is our second case. Pre-op, 24-hour post-op, immediately recovered, was very, very well. This was about 6 weeks later. His scan, and this is personal communication between me and my colleague, where we were discussing that he's got some orbital involvement. His vision was, I think, even 6.6, completely fine. This eye needs to go. He refused. That was post-op. That was just mucosal thickening and scarring after his surgery. He had no mucosal disease. He refused to have that's a fungal load in my view. And he then got readmitted, disseminated mucormycosis. While I was in England, admitted to Ain Shams University Hospital, died of stroke, and he got COVID for the second time. That is the same case. Just wanted to highlight this area of his orbital involvement. Anyways, very quickly, that's what you would see intraoperative, black charring, gunk. Here is this second case's middle turbinate. I don't know if you can see that. Red mucosa, but the posterior half of the septum you'll see is white ischemic. That's their middle turbinate. That is the middle turbinate on the right-hand side. So his ethmoids are nice and clean. There is no evidence of necrosis, but he had just a simple necrotic middle turbinate. That was all he had. But it lives all over in the mucosa. So it's not just what you see, unfortunately. That is one of our patients who died within 24 hours in ITU. So I'm sorry to come across with this grim talk, but that is mucormycosis for you. Thank you for your patience.